So probably the people that have impacted me the most in my life have been people that didn't believe in me. And the reason for that is that I didn't believe in myself, because I didn't know what I wanted to do with my life. Introspection really defines who you will be and what you will make of your life. So once I figured out what it is that I wanted to do, I set down this huge and long educational quest for excellence and to never having any doubt in my life. Throughout this quest, I met some incredible people that supported me, and I knew exactly what I wanted to do. I went to dental school, medical school, figuring out where to go, a lot of postgraduate education, residencies, finally a fellowship abroad in Taiwan. I was ready now. This was the drive. The drive was to achieve excellence, not have any fear, and more importantly, take care of people as a surgeon. The first job that I had after I completed my residency training was right here in our backyard of Baltimore, the busiest trauma center in the nation. I had the armament ready to take on every difficult and complex problem that presented through the door. And I can tackle it with precision and accuracy. But there was one problem that was unsolvable: the central facial injury. A central facial injury commonly is a result of a high energy, usually a ballistic injury or an evulsive injury, that is a triangular component of your face where your nose is gone, your upper lips, lower lips, jaws, teeth are totally gone. Now, we can commonly take tissues from your body, from your arms, from your legs, to try to rebuild your face, but it never looks normal. It never functions normal, never appears normal. You constantly drool. So it's an unsolvable problem. And when you look at the face of this individual who has to wear a mask every day of his life, and he feels that he can conceal himself, but we know when we wear a mask, we all want to know what's behind that mask. So actually he's gaining more attention. So just for a minute, imagine yourself living this way every day of your life. We know that when we have a pimple in our face, we look in the mirror and we think, oh my God, it's a volcanic eruption. I'm not going out, I'm not going to face the world this way. And this is how Richard Lee Norris lived his life every day, a courageous individual. He concealed himself from society, shopping at night, trying to avoid physical contact, avoiding embarrassing situations. So the real question is, was face transplantation the solution for this individual? At this point in our time, only a handful of transplants had occurred. As a surgeon, I have a moral and ethical obligation to ensure that when you're asleep, you have no control of your life. I am totally in charge of what's going to happen to you in that particular moment. So it's my responsibility to ensure that you come out of there safely with an incredible result. There were a lot of questions that were not answered. And that's why we set out to try to answer these questions, trying to figure out what were the limits of possibility. And we had to go into the realm of impossibility. When you look at the face transplants that have occurred throughout the world, it's hard to say that the patients really look amazing and can integrate back into society. But our patients had to be perfect, because it's the only way that they can integrate back into a normal society without anybody really looking at them, staring at them. So we needed a very strong research foundation. We had to answer some questions. And this whole project was basically to care for the wounded warrior. It was a wartime protection program. And that's where it all began, to care for the same type of injury that the soldiers were experiencing abroad in Iraq. After many years of research, we found out that when we did our face transplants, the inclusion of bone was a valuable element, that the bone allowed for longer-term graft survival, and the faces would not reject. We could reduce the amount of medication, Keep in mind that these medicines that the patients will take will be for the rest of their lives. And there is a cost to taking those medications which could compromise your life. And we don't even know how long the face transplants will live. So just imagine yourself signing this document. So we began to recruit patients. This is a research procedure, not your standard consent. And we identified one individual, one very courageous individual. The deformity that he had was the central face. You can see that he's missing his lips, missing his teeth, missing his bones. His nose is not normal. Forehead is damaged from previous surgeries. The height and width of his face is not entirely normal. And we're going to push the boundaries. We're not just going to take care of the area that's typically injured, and we're not going to also work on the forehead, but we're going to extend the limit so when he walks into this room, no one will know he had a face transplant. His ultimate goal was just to be an average person, just like all of you. And we knew that with current surgery, there was no way we could ever get him back to what he wanted to look like before his injury. Repetition is the mother of all study. If you haven't noticed, this is Latin, unlike me, who's Latino. Repetition is the mother of all studies. And you have to practice until it's perfect, and you have to continue that over and over and over again. And how are we going to do that? Well, we created an environment that we can practice on cadavers, and we did 15 paired cadaver dissections. These were real-time with our entire team. I was able to select an elite group of surgeons, small group. They were very young, and you'll see a photograph of them shortly. But these were individuals that I knew that I could trust. We were all interchangeable. We could do each part of the operation. Keep in mind, the donor and the recipient operation are going to be going on concurrently. We practice and practice and practice until we could do this in the sleep. Irrespective of all the practice, a cadaver does not really simulate the real situation. So I petitioned our organ procurement organization in Baltimore to give us the opportunity to practice on a patient, a brain-dead donor. This is a remarkable opportunity. It's a difficult question. It's really the unthinkable question. Imagine yourself being in the most difficult moment of your life as a family member, and we are asking you to allow us to practice on your face, of which that face will not be transplanted to another person, so that we can successfully help out humanity. Very difficult. That's why we were partnered with an incredible group that questioned these families, and every member was always willing to help out their fellow man. So I'd just like to take a moment of silence for all these incredible and generous families that really gave the most altruistic gift to make this happen. You will never be forgotten. So we practiced, we went in that room, we went into a new environment with transplant surgeons. We were the new kid on the block, and everything was perfect. We were able to make this happen. Things worked very well. We had complete buy-in from our nurses, our staff, anesthesiologists, the transplant surgeons. It was a remarkable moment. The institution was behind us 100%. An incredible part of this mission is to have an anaplastologist, a person who is going to make a replica mask of this patient. Keep in mind, we remove the face, so that patient has to leave the room whole. It respects the integrity of the patient and also respects the family's wishes. So after much blood, sweat, and tears, we were essentially ready to make this happen. A clinical face transplant occurred on March 19th and 20th of 2012. And you could only wonder, what am I thinking? Have I done everything possible? There's a lot of doubt. Is our team too young? Is it too small? Did we practice enough? We're going beyond the limits of what we can do. It's never been performed before. Are we really going too far in the boundaries? Is this what it takes? So I'd like to define to you, what is a face transplant? And in Richard's case, it would involve replacement of the face from the top of the head, in front of the ears, cheeks, nose, lips, all the skin down to the clavicle. We would include all the muscles of facial expression so that he would have a normal smile. He could open his mouth normally. The underlying bones with the underlying teeth would also be included. With that would come the blood vessels and the nerves that would move his face, that would give him normal expression. In Richard's case, the incisions would begin around the eyes, and we would extend those incisions from the top of the hair down to the clavicle. We would remove everything that surgeons had worked on for 15 years. The tissue flap would come together as a composite flap, all the skin elements, all the muscular elements, all the bone, with the blood vessels, with the tongue, everything as one piece. The skeleton would be stabilized with plates and screws, then the blood vessels would be connected appropriately, the nerves of facial expression would be connected, and the final step was the redraping of the soft tissues, extending all the way back to the hair-bearing region. We excise more of the hair-bearing region of Richard so that we can conceal the incisions so when you stood in front of them, you would not see him. So we're actually removing tissue that's actually normal. So we're going beyond the boundaries of what's been performed before in facial transplantation. So what's the point of no return? What's the scariest moment for me when I remove Richard's face? Complete silence in the room, and I'm wondering, this could either be our proudest moment, but it could be our biggest failure. There's no return now. Now we have a mission to complete, and we have to ensure that Richard's operation is successful. For normal patients, the worst that we could ever expect is death. In Richard's situation, dying is easy. But if he survives and he's worse off than he was before, on immune suppression, without the normal ability to mount a normal response to infection, he would likely die a very painful death. So we left no stone unturned, and we brought in every aspect of technology that we could. We did what's called computerized surgical planning, that we could actually simulate surgery on a computer before we actually did it on Richard. And how would we know that the skeletons would match? Well, we got the donor skeleton from CT scan, and we could simulate the matching, so we knew exactly where we had to shape the bones. We knew where we had to put the plates and screws so everything would fit, and we'd limit the amount, what we call ischemia time, when the face is not being perfused with blood. We also use intraoperative navigation. This is essentially video games, planning exactly where to make our cuts real time in the operating room, making this operation as precise as it could possibly be. How would we know if it would live? Well, we use vascular imaging. This is state-of-the-art. We inject a dye in the blood vessels, and while the face is being procured, maintained off the blood vessels, we know exactly that every millimeter of skin will live. So we've done everything that we could possibly do from our part to ensure success in this patient. The images that you see here before you is Richard's skeleton before the operation, and we're planning to remove what's outlined in green and in gray, recreating the initial deformity as you see here, going back to the day that he was injured in 1997, and this is the actual result that we were able to achieve. Replacement of the skeleton, replacement of the teeth, everything is stabilized with the hardware. These are the photographs that were released on its postoperative day 6, and the most recent one from postoperative day 114. Everything went exactly as planned. Thank you. As you can see, preparation was worth it. The success is remarkable. Richard is doing amazingly well. He's an incredible patient. He does everything we tell him. He's committed to every exercise that we ask him to do, to speech therapy, physical therapy. When does the worrying end? I will tell you that it never ends. It doesn't end when you come out of the operating room, doesn't end after you get your first episode of rejection. You're always wondering what's going to happen. Our first face transplant in the world occurred in 2005. I'm often asked, how were we able to handle 36 hours of operation? It's pretty simple. For the mothers and fathers in the room, if you have a child that's sick, I guarantee you don't take a break. For Richard, we had a task to complete, and that would not end until he was out of the operating room safe. I'd like to introduce to you to the members of my team, the miracle workers that made it all happen, the elite group of surgeons that I have a fortune of being a member of their team. I believe in miracles, and they happen every day. Thank you.